The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thank you for joining us today. This webinar will begin in 2 minutes at the top of the hour. Again, we will begin in 2 minutes. Thank you. Hello, everyone. Thank you for joining us today. The webinar will begin in 1 minute at the top of the hour. Again, we will begin in 1 minute. Thanks. Good day and welcome to this Health Catalyst webinar. As a quick introduction, Health Catalyst is a next-generation data, analytics software, and decision support company committed to being a catalyst for massive, sustained healthcare improvements. My name is Sarah Stokes, and I will be your moderator today. Now let us begin with today's webinar, Getting to the Wrong Answer Faster with Your Analytics, Shifting to a Better Use of AI in Healthcare, presented by Jason Jones, Chief Data Scientist here at Health Catalyst. Prior to joining Health Catalyst, he served at Kaiser Permanente in various roles, including research scientist and VP Information Support for Care Transformation. His mission is to leverage data to achieve the quadruple aim. Today's webinar is an interactive one. You will be presented with multiple poll questions, and we encourage you to participate in these polls as they will help to steer today's conversation. We also urge you to submit questions throughout today's presentation via the questions pane in your GoToWebinar control panel, as Jason will answer questions at the conclusion of the presentation in a Q&A session. We are recording today's webinar, and by midday tomorrow, you will receive an email with links to that recording, the presentation slides, and a transcript. If you'd like to stay in the loop on upcoming webinars and all things Health Catalyst, you can follow us on social media. Our handle is @HealthCatalyst. I will now turn the time over to Jason. Jason?
Thank you, Sarah, and thanks to each of you for joining. Deeply appreciate it. The title may seem a bit odd, getting to the wrong answer faster with your analytics. Usually we don't want to get to the wrong answer faster, but I'm hoping that you find this engaging, understand what kinds of things might count as a wrong answer, and if we skip to the learning objectives then, let's see how it is that data can both help us draw the right and the wrong conclusions. My hope, to borrow a bit from, I heard it from Maureen Bisignano at the Institute for Healthcare Improvement, my hope is that you can walk away with this with 2 things that you can do next Tuesday to help your own organizations arrive at the right answers as quickly as possible. And we'll go through a couple cases of how it is that we can drive better analytics. So the first thing is, and I hope that you can use your imagination for this, put yourself in the circumstance where you're moving to a new place, let's say a state or a small country, and your goal is to buy a house. The problem is that you've heard some reports that some of the regions in the state may have more cancers than others, and you definitely don't want to buy a house in an area that has more cancer. You wouldn't want to put your family or yourself at that kind of risk. So the good thing, if there is a good thing about cancer, is that it's a reportable disease, and so you were able to download for yourself all of the data for every cancer that has been reported in this state that you're going to be moving to. And on the right-hand side, what you can see is the latitude and longitude and the region for each one of those reported cancers. So for instance, the first 4 cancers reported there each happened in region A01. And then there are 2 cancers from A02, 2 cancers from A03, 3 cancers from A04, and so on and so forth. The list goes on, and on. In total, there have been 400 cancers that have been reported. And again, your goal is to figure out, can you use these data to help you decide where you should buy or not buy? And as we go through this example, what's important is that for this learning objective, for this experience, we're never going to add any more data than you're looking at on the screen right now. There are more rows, as I mentioned. We're only looking at the top 19, and there were 400 cancers, but you're never going to have to worry about, oh, are there genetic differences or other underlying population differences or different population densities or anything like that. So the goal here is not to trick you, not to ask you to do some kind of advanced analytics. It's just to go through how it is that we might best represent the data for you to drive a conclusion about where it is that you should or shouldn't buy a house. Okay, so again, this is one way we're showing representation of all of the data that we have. And we know as human beings that we can see things when they're visualized as a picture much more quickly than we can as raw numbers. So here we're looking at exactly the same data as before. And you may recognize, for instance, if you look in the lower left-hand corner, that's the A1 region that we saw at the top of the table before, and you can see it goes out to J10. So we have 400 cancers in 100 different regions of the state that you're moving to. And hopefully you would agree that you could more easily digest the information in this picture than looking at the table that we were presented with a moment before. And Sarah, I'm wondering, does anything just pop out to you already where you'd say, ooh, I don't like the looks of that region, or I do like the looks of this one?
There's a couple of blocks, right? Maybe down by that B3, B2 area. There's kind of a cluster there.
Mm-hmm.
Or C7 also looks a little nasty.
Okay, so those are areas where you'd say, I'm not sure I want to buy something there.
Right.
And how about, is there anything that just pops out where you say, ooh, there's an open space. It doesn't look like there's any cancer there.
Maybe H7 looks okay.
Mm-hmm.
And A9 also looks okay.
Great. Okay. And hopefully if you're able to see this on the webinar, it's going to be a little bit tough if you're only on the audio part. But hopefully, you can start to draw some of your own conclusions from this. And of course, we can ask the computer to do a bit more for us. So for instance, we can say, let's add some grids and then some colors to this. So what we're looking at right now, again, we haven't changed the data at all, but what we've added here is we've highlighted those regions that have more than 2 times the typical number of cancers. So anything where you see an orange triangle represents having at least double the 4 cancers that we observe on average. And the red one is the region that has the single highest cancer rate. We can also have the computer highlight for us where it is that there are no cancers at all. So now the green circles show us, and Sarah, you were spot on, that H7 region, for instance, has no cancers at all. We can see there's another one, A9, where there are no cancers. And so we can use the computer and visualization techniques to help us better be able to see what's going on with the data, and that can really help us draw conclusions. So Sarah, when you look at this, is there anything, would you change your answers once the computer has helped you identify where the cancers are?
I mean, I think the good areas are still good,
Mm-hmm.
but I guess there's a little more info on the quote bad areas, right? The red, I definitely wouldn't want to be in the red.
Mm-hmm. Yeah. And it might have been a little hard to see that. I mean, you actually did pick up on it, but that those cancers are almost right on top of each other. It's almost like there's a big apartment building there or something, or condos or something. It's just, it might have been harder to spot for some people. But again, the computer can help us visualize. And just before going to the next slide, if you can get your computer, or if you have a smartphone or something handy, we're going to ask you as the first poll question to go ahead, and at the bottom you can see that there's a URL. And if you can go to that URL, you will see the picture that's on the right-hand side of your screen. So I'll read it for you. It's you don't need the HTTPS probably, but the buying a house, all one word, buying a house dot azurewebsites.net. And again, you'll be presented with the screen that you see here. And if you're on a smartphone, you can just tap where you want to buy or not buy a house. And if you're on a computer, you can click. It'll ask you to confirm your responses. And we'll just give you a couple minutes to put in your information. And just to test it, I myself am going to go into the app here quickly and see how long it takes me so I don't rush you too much.
Great. And I guess while we have some downtime, I'll remind everyone, if you joined late, we are recording today's session. You will have access to the recording and the slides after the fact. We'll get those posted by about midday tomorrow and send you an email letting you know those are available. And we are holding a Q&A at the conclusion of today's session. So if questions come to mind, be sure to submit those and Jason will get to them at the end of today's presentation.
Great, so we're getting some responses, but not quite as many as I would hope. So again, if you have a moment to go in and go to the URL, we're not tracking, I should have said, we're not tracking anything about you. It's an open website, just trying to see what kinds of patterns we see with the audience here. So it looks like we're starting to see a pattern, and we'll go forward now. But again, you're welcome to enter your responses at any time. So we'll go forward and click on the results, if I can make the mouse work. Where's the mouse?
I can see it here.
Okay, so I just can't see it on my screen, so I'll go ahead and click.
Oh, well,
nope.
Let's see, let me try. Sometimes you have to wiggle it. There we go.
Okay.
You just got to get a little quick with it.
Okay, there we go. So we're looking at the same screen that you might have seen, but now what we have the opportunity to do, and you can see this yourself if you went through the app, is we can see based on your responses, where did people buy? And it's shaded by region. So we had, the most responses in this H7, and the next most responses for where to buy a house in this A9. And I wish we could ask all of you why you elected to choose what you chose. So I'll ask Sarah as a proxy for all of you. Sarah, why might you be inclined to buy an H7 as opposed to A9?
I would say probably because of the proximity to that A10.
Yeah. It's a little scary. Like, what if cancer really is infectious and some of these people start to
you're
start
definitely
to walk
closer
over?
then. Yep.
Okay. And then if we go to the not buying a house, where are people not buying a house? And it's interesting, B2 is now jumping off the map. And I'll just have to tell you, historically, that if we don't highlight those red dots, which we can do when we're in a more intimate setting and ask people to step through different phases of what information we show, people tend to be more inclined to pick up on the C7 and the D10, I think largely because of, it's just easier to see that there are a lot of points there.
A little more spread between the points.
Yeah. So based on this, it seems as though most of you are agreeing with Sarah as your representative about where it is that you would and wouldn't buy. So we'll get out of this and go back to the presentation. And thank you so much for being willing to place your votes there. So there is another way to look at these data. Before, what we were doing was looking at the geographic distribution on a grid. But the other way to look at it is just to say the x-axis here, this is a bar chart you're probably pretty familiar with, but we have a bar chart here, and what we're showing is how many sectors had how many counts of cancer. So you can sort of see, we'll make it a little bit easier to see in a moment, that there were 2 sectors with no cancers at all, and about probably it looks like 5 sectors that had 1 cancer, and so on and so forth. Let's make it a little bit easier to see. So now we're highlighting in green on the left-hand side those 2 sectors that you all decided you wanted to buy a house in that had no cancers at all. And on the far right-hand side, we can now see that one sector actually had 10 cancers, and the 2 orange sectors each had 9. So now we know how many sectors were out there. And Sarah, again, as the representative of the people here, what do you notice about when you look at this bar chart? Does it look like any famous distribution that you learned about in your favorite class, which was introductory statistics in college?
Oh yeah, my favorite class.
Yeah,
Definitely looks a little bit like a little bit slanted bell curve.
a bell curve. Yeah, and maybe hopefully that's what it looks like to those of you who can see the picture. And again, thankfully we have a computer to draw this in the first place, but we can actually use the computer to actually smooth out the distribution. And this is what it looks like with the computer smoothing out the distribution. And Sarah, I think most people would agree with you that this does look like a bell curve. And to your point, it's slanted because we're dealing with count data. So we can't have like -1 cancers or
Right.
-2 cancers, whereas we could theoretically have 100 cancers. That would be definitely a region to avoid. So if we know that this is looking a little bit like a bell-shaped curve, and for those of you who really, really, really loved that intro stats class, you may remember there was something called a Poisson distribution, which is specific for count data. We can actually have the computer say, well, what would we have expected to see? What would we have expected the distribution of cancers to look like if it was completely random, meaning if it had absolutely nothing to do with geography. And so that's the purple line that we've just overlaid on top of the blue line in the bar chart. And Sarah, how close does the purple line look to the blue line to you?
It's pretty close.
It is, isn't it?
Yeah.
I mean, there are definitely some gaps there. It
Hmm.
looks like the the theoretical distribution actually expected only 1 region with 0 cancers, and we observed 2. So there are some slight differences. We can see some gaps between the blue and the purple line, but that blue line, which is what we observed, looks really close to what we would have expected to see if there was no association between geography and cancer risk. And it turns out that we can run an actual statistical test to help us understand that. And you may or may not remember p-values from before, but the test that we're, whoa, somehow we've missed the result of our test in the deck. So I'll just have to tell you that the p-value when we run the test is 0.99. And you may remember that if a p-value is less than 0.05, that we would say, ooh, there's a 1 in 20 chance that what I'm observing could have happened by random chance, but 0.99 is about as close to 1 as we can possibly get, which is telling us that what we are observing is we can probably safely conclude that it's just due to random chance. So Sarah, again, as the representative of the people here, how might you change your answer about where it is that you might buy a house or not buy a house?
I mean, I guess then I'm not really limited, right? Because it doesn't matter, so I could pick anywhere.
Yeah, you
Yeah.
could say, well, I'll pick the one that has a nice view, or I'll pick the one that's
Right.
close to a good school district or in a good school district or
Hmm.
something like that. Or whatever. I like the neighbors. You can make it on whatever you'd like, but cancer risk does not need to weigh heavily on you. Um, so what have we demonstrated here? So what we've demonstrated, I hope, is that we can do wonderful things with data and computers. We can visualize information to help us spot things that we could not have seen before. And human beings are really good at spotting things visually. That's how we work. But what we need to be careful about is that just like you can lie on the grassy field in this wonderful new state that you've moved to and see a dragon in the clouds, in fact, there isn't a dragon in the clouds or an elephant or whatever it is that you see when you look up at the clouds in the on a on a cloudy day, and we can make exactly those same mistakes in analyzing our data. And the good thing is that we can anticipate the types of errors that people are likely to make. And so the rest of this discussion is going to be how can we anticipate those errors and then bring AI to help us prevent ourselves from the kinds of routine mistakes that we might otherwise make. So now we'll go forward, and I'd be really grateful, Sarah, if you could, as the representative of the people, ask the people.
Yeah, absolutely. Okay, in our first poll question here, we'd like to know on a scale of 1 to 5, how useful did you find this exercise? So your first option is 1, not useful. Maybe you thought it was a silly example or it was information that you already knew. Then we have a 2. Then we have 3, which is ambivalent, might help someone somewhere, but not me right now. Then we have a 4, and then 5, extremely useful. You learned something that you can leverage today. We'll give you just a moment there. Votes came in pretty quick. Everybody's on the ball today.
Wow, thank you so much for responding to these questions. We're going to get to another one in a moment that truly is going to direct the course of this session, but your responses here will direct the course of how it is that we try to explain things going forward. So thank you.
Okay, close that poll. You're good to move on.
Okay. Okay. Oh, how do we get the results?
Oh, you want me to share those?
Yes, please.
Oh, okay. Then I will go ahead and do that. There you go. So people thought it was pretty useful.
Yeah.
Here, what is that? 69% said 4 or 5.
Okay. Wow. Okay. So as a net promoter score, we're doing okay here, and it looks. Would love to hear from people who put in a 1, 2, or a 3. If you want to type in, is there anything that we could have done to make this more useful for you? So please do let us know if you're willing to contribute your thoughts as we go forward.
Okay.
Okay. So back to our presentation, and now what we'll look at are some of the ways that we can actually make a difference. And we're going to start with a couple of examples here. Whoops, let me click back here. Okay, so we're going to go through 2 examples. I wish we were all in a room together and I could ask how many of you have ever seen or watched Scared Straight. It was a TV show that started actually in 1978 as a documentary, and the basic idea was that you take some teenage delinquents and you put them in prison for 3 hours, and the whole idea, which was a wonderful idea, was that I mean, you sort of wish people didn't commit crimes in the first place, but if someone is going down the path of delinquency early in their life, then is there some way that we can help them change course? That was the idea. And so we put people in prison for 3 hours and basically scared them. And the idea was, well, we can scare them into not wanting to go further down this path. So the only thing is, and I think, some of you may a priori think that's a great idea or a bad idea, but people really did think it would be a good idea. The only bummer is that we've now done 9 rigorous studies on this, and it turns out that 2 of those studies showed that there was no benefit at all, and 7 of them actually showed that there was no impact whatsoever. Or sorry, 7 of them showed that there was actually a net negative impact, so it actually increased delinquency. we'll see the rates in a moment. I'll just point out at the bottom, if it's a little hard to see, you will get these slides, and I just want to be clear about giving credit where it's due. I did not come up with this. There's a wonderful book called Doing Good Better, and the link to it is at the bottom. And then there's also a blog at the bottom, and you'll get these slides, and you can go to those links if you would like to. So what is it that the market should buy then? And you can probably search for this yourself on the internet if you didn't know. But I looked last week, and when I searched for Scared Straight TV, it turns out that you can watch this show today. So more than 40 years later, if you search for this on the web, you can go watch this show. It's still running. And how do we think about this? I mean, this means that society is willing to pay via commercials and other things to continue watching this type of show. And I won't comment on the image that's selected, which I'm sure was not random. And here we have the other side, which is that Cochrane review that I mentioned. And again, you can the link for the Cochrane review, if you're interested, you can go see. And I'll read because I think the text will be too small. But highlighted there is that the intervention, meaning Scared Straight, increases the odds of offending by between 60 and 70%. So not only did Scared Straight, as a perhaps reasonable hypothesis of how it is that we may help people avoid a life of delinquency in prison, not only did it not help, it actually has been demonstrated to hurt terribly. There aren't that many things that we can do where we can improve something or make something worse by 60 or 70%. It's a pretty massive effect. And yet, more than 40 years later, it is still going strong. But I don't want to end on a negative note. I'd like to end on a positive note. And this is one that is going to turn out to be positive and show how important, if you're in the health and healthcare world, how important your contributions can be. So the next one is about books and worms. So what is that about? So here, there's an organization, wonderful organization. Its goal was to try to improve academic performance for kids in Kenya. And one of the things that this organization noticed when they went to go look at the classrooms is many classrooms had only one book for the entire room. And how many of us would send our kids or be willing to send other people's kids to a class where the entire class had to share one book? We'd say that's nuts. How are the kids supposed to learn? So the first thing they did was provide more books. And as they did so, they were careful to study the impact. And what they found was that providing more books didn't help at all. In fact, in some sense, it hurt. There was an odd finding, which people have theorized why it was found, but there was an odd finding where giving more books to the class as a whole actually did slightly worse. But the highest performing students, the historically higher performing students, did a little better. And we can hypothesize why that might be the case. One of the reasons that they were pretty confident the books didn't help is that for many of the kids, the books were in English and English was their third language. So great, you give them a book in a language that they struggle with, and then it's no surprise that they're not able to learn. So then they said, okay, not a problem. The other thing we've noticed is that the teachers are kind of hampered. They don't have great blackboards if we're trying to encourage group learning, which we may want to do if it's English as a third language. Then let's provide flip charts to these classrooms. And again, they studied providing flip charts. It didn't help. Similarly, they thought, well, maybe we should provide more teachers, and that didn't help either. And each of these was carefully studied, and we're really grateful that those studies were done. So the organization got a little bit dispirited, as you might imagine. They went in with the best of intentions, and each intervention didn't work, and it seemed so obvious. And if these things don't work, what the heck do you do? And it turned out, and again, I'm relaying a story that you can read about in this wonderful book, but it turned out that one of the leaders in the organization knew someone in the World Health Organization, and that individual said, well, one of the main drivers for kids missing school is that they get worms and then they can't go to school. So why don't you do deworming, which I think most of us would acknowledge is pretty far away from, you'd have to be a pretty creative person to think about deworming as something that can assist in test scores and academic performance. But what they found was not only did deworming help, it decreased in the short term absenteeism by 25%, which is really impressive. But careful study 10 years later showed a net 20% increase in income. So just astounding, the positive impact that we can have. But importantly, how do we know? We know because someone took the time to study what was working and not working carefully. They didn't just assume that the best of their intentions, coupled with good implementation and solid theory, would automatically yield better results. They actually measured it. So we can do wonderful things. Okay, Sarah.
All right, so we are to our second poll question here. And in this poll, we'd like to know, when was the last time you suspect your organization drew the wrong conclusion in a preventable way? Bad data or methods? And your options are number 1, within the last week, number 2, within the last month, number 3, within the last quarter, number 4, within the last year, and number 5, it's never happened. It's never happened in your organization. We'll give you just a moment here to submit your responses there. And the votes are coming in pretty quickly.
Wonderful. Thank you so much again for participating.
We'll give you just one more quick moment. And again, I'll remind you all that we are recording today's session and you will have access to the slides after the fact. Okay, we're going to go ahead and close that poll and share the results. Okay, so it looks like 31% said within the last week. And that is your majority.
Mm-hmm.
Then 25% reported within the last month, another 25% within the last quarter, 17% within the last year, and 2% said it's never happened.
Wow.
So your vast majority are within the last quarter, over 75%. So
wonderful. Thank you for providing that. And the only way that I've ever been able to avoid mistakes is by erasing my memory. Some of you, I think, are more effective than me. Okay, so thank you for that. And we have a hypothesis about why it is that, especially in health and healthcare and more broadly within data and analytics, we might have found ourselves where we are today. And there are many contributors, but I'd like to address one of the common images that's out there. And I want to be clear, we'll get to some awesome things about this image as well. But this is the Gartner Analytic Ascendancy model. And again, I think it's done a lot of good, but there are also some challenges that we encounter fairly routinely with people literally interpreting the path as well as the value proposition. So the first thing is that we routinely find that these basic descriptive analytics are not a solved problem in our world, especially in health and healthcare. We have all kinds of challenges collecting basic data and making sure that the right data are standing up for analysis. So until we solve that problem, we can't easily be able to move through the rest of the ascendancy, and we need to remember that and focus due attention on the descriptive statistics. The second is that we have the diagnostic and predictive analytics in the wrong order. It is an order of magnitude harder to be able to demonstrate why something happened as opposed to predict what will happen. And again, for any of you who can remember a basic statistics or research methods class, you may remember the phrase correlation does not mean causation. And predictive analytics, all you need to know is correlation. To be able to establish causation or why something happened is really, really, really hard, 10 times harder than prediction. So we find with many of our customers that by not understanding that, we focus again on solving the wrong problems. And then the last piece is about prescriptive analytics, and the headline there is how can we make it happen? But the part that gets left off is we find that's actually usually not an analytic problem at all. That's a change management problem. That's where we need to be able to support leaders and workers and others so that we can see the change that the computer or something else is suggesting that we make. It's not actually an analytic problem. I will point out there are many good things about this diagram, but the thing that has been particularly wonderful for me is I have learned to use the word optimization instead of evaluation. So I used to say, hey, let's set up an evaluation or a study to figure out how things are working. And what I've found is that if we simply swap out the word evaluation, which most people don't think of favorably any more than they would some kind of a diagnostic exam that causes you pain or other kinds of misery, no one really loves doing evaluations, or few of us love doing evaluations, but just about everybody wants to optimize. And it turns out that we can take many of the same steps for an optimization problem that we could for an evaluation one. So one recommendation, if you use evaluation and you wonder why people won't get excited about it with you, is that we can switch to using the word optimization. Okay, our next poll question, Sarah.
All right. In this poll question, we'd like to ask, what is your chief complaint? Your first option is low analytic throughput. Second option is low data literacy. Third option is lack agreement on definitions. Fourth option is don't believe results. And your fifth option is pilot-itis, too many or too long. You want to provide any additional details on any of those?
Yeah, so this is going to direct the rest of our time together. So we'll go in rank order here, and also get ready with any questions or comments that you have, and we'll try to be responsive as we go through. So please take a moment to vote what's most important to you, and that will determine the order of the rest of our time. Thank you.
Okay, great. The votes are coming in a little slower on this one. I think it's making people think about.
Okay.
Yeah, I see a comment here, need multiple choice here.
I know that's somehow true. So chief complaint, for those of you who aren't familiar, is what you often come into the emergency department with, like my arm is broken, or I have the sniffles, or I'm having a heart attack. And it's for those of you who are physicians or nurses or other providers out there, especially in the hospital, how often do we wish that patients would agree to only have one problem at a time? Wouldn't that make the world so much simpler?
All right, we're going to go ahead and close that poll and then we'll share the results.
Okay,
So
ooh.
18% voted for low analytic throughput. 34% voted for low data literacy. That's our highest here.
Okay.
31% voted for lack agreement on definitions. 8% voted for don't believe results, and 10% voted for that pilot-itis.
Okay.
So it looks like we're starting with data literacy, then moving on to agreement on definitions and low analytic throughput.
Wonderful. And the content here is going to be a little on the light side, and that's not an accident. It's to try to encourage some thought and some dialogue. I had to wiggle the mouse there, so I'm going to click on low data literacy. And it's going to take a moment. I'm just going to describe what we're looking at. But the idea here is we often say that, well, the problem in our organization is that we can't provide people with more sophisticated analyses. They won't be able to understand them. So please just give me my standard business intelligence report that looks beautiful. And what we're looking at here is a report. You may or may not love the aesthetics, but it's a report that's incorporating a lot about what we know and love from the field of AI. So let me describe what we're looking at first. So the first thing is we have a measure here. It's some kind of a key performance measure. We have 7 different geographies and how the system performs overall. On the x-axis, what we're looking at is their performance measure, which is ranging from about, it looks like about 63% up to the mid 80s to high 80s. So that's what we're looking at. Each of these points represents the performance. So we can see G1 is the best performer at something like, we'll call it 85%. and G7 is performing around 63, 64%. So those are what those triangles represent, and hopefully you can understand we have the different geographies, the system overall, which is at around about, call it 77% or so. And then a couple of other things to orient you. Green is the direction of good, so we would like the geographies to be over towards the right-hand side. Blue, the solid blue line that you're looking at here, is a goal that has been set within the organization. And so hopefully that basic background is fairly easily recognizable to you. The performance by geography, snapshot in time, we know what good looks like, and we even have a goal that we have set for ourselves. So now let's go a little deeper into some of the additional information. The first thing is these lines that you see spreading out represent confidence intervals. And if you're not sure what a confidence interval is, perhaps for the purposes of this brief discussion, think about it as where it is that we would comfortably be able to say the triangle actually fits. And the first thing that you'll notice probably is that some geographies have much, much broader confidence intervals than others. So this G7 has a much broader confidence interval than the system as a whole, or even if we look at these top two geographies here. And what that's telling us is that the underlying sample size is much, much smaller for this geography down here than it is for this geography up here. And again, the same approach could apply to geographies, it could apply to providers, it could apply to whatever, hospitals or medical office buildings or whatever. And we know that some geographies, some hospitals, some medical office buildings or whatever have larger populations than others. So this is automatically taking that into account for you, so you get a sense of what the variation is around the measurement. The next thing that you might notice is that the colors are a little different as we look at the different geographies. And if you're colorblind, there's some letters off to the side that are in gray that are telling you how these geographies cluster together. So even though geography 1 is numerically the best geography in the system, it turns out that it's statistically tied with geography 2. However, geography 3 is meaningfully worse as a performer than either 1 or 2, and is tied with geography number 4. Then geography 5 is a little bit worse. Geography 6 is a little bit worse than that. You can see the colors changing and also the letters changing. And finally, geography 7 is worse. So we don't have to ask ourselves, geez, are 1 and 2 really different from each other? Or are 3 and 4 really different from each other versus 5? The computer can tell us that using fairly reliable and rigorous methods. The last thing that you might notice is that we have these gray diamonds out here. And what the gray diamonds are telling us is not what our current performance is, which is represented by the triangles. The gray diamonds are using an automated forecasting or projection technique by the computer to forecast if history is a guide and we consider the complete history of these geographies, where do we expect them to be a year from now? So what we can see now is that although regions 1 and 2 are tied with each other, they actually appear to be heading in different regions. And although we might have been equally concerned about region 3 and region 4, we're leveraging AI to tell us a little bit more that in fact we should be, if we're concerned, we should be a little bit more concerned about geography number 3. Geography number 4 is projected to actually improve, and not just improve, but improve beyond the target. So this is helping us draw much more information from the same data that we would ordinarily have, but it's providing more information. And what it's providing us then with that additional information is the opportunity for us to get on the same page. And I wish we had a poll question here, but we wanted to limit the number of poll questions, because the question that I hope that you would answer favorably is that most of us, even non-analytically minded people, can actually understand and interpret this picture. And perhaps more importantly, it helps us all get, as I said before, it helps us all get on the same page, which then vastly facilitates the discussion and the conversations become more meaningful. So we may come in with a perception that we have low data literacy, which often can be low analytic capability within the people who are consuming the information. That's often the interpretation. But we've found that there actually are ways to present the information, leverage the computer at what it does best, prediction, forecasting, things like that, to help even the least sophisticated, the least analytically sophisticated users address meaningful, understand meaningful concepts in their organization. So that is an example of how it is that we can increase data literacy, not by running away from statistics and machine learning and standard reporting, but actually by embracing machine learning and statistics in our standard reports. Okay, so next topic. Can you help me out, Sarah? I can't remember what was next on the
Yes,
list.
the next was the lack of agreement on definitions.
Okay, this is a great one. And my poster child here was arguing for long periods of time over what would count as a hospital readmission and how grateful I was. I'm not often grateful for CMS or Medicare, but boy, was I grateful when they adopted and told the rest of us how to measure readmission, because at least we could stop arguing over the definition and then start acting upon what we were seeing in the data. But there is another approach, and again, the graphic here is really small, and that's only partially an accident or a mistake. The real thing that I'm hoping you can see is that we have a line that's running down the middle here. And any points that we see on the right-hand side of the line are saying something is better. Any confidence limits that are on the right-hand side of the line are saying that older is better. And anything on the left-hand side is saying that fresh is better. Now, what might old and fresh mean? So, Sarah, if I asked you, you need some blood. I can give you old blood or I can give you fresh blood. What blood would you like?
I definitely think I'd like fresh blood.
You'd like fresh blood? Yes, yes. I think most grocery stores only stock fresh blood now. No. So believe it or not, and some of you who are in the hospital may know this. This is an actual issue. You frequently will have patients who need blood, or perhaps you're someone yourself who has needed blood. And the challenge for people who manage blood banks is, well, what do you pull? Because you can imagine if you always pull the freshest blood, well, that means the next person who comes in, unless you get a new blood donation, is then going to get older blood, and pretty soon you're going to have some pretty old blood. But we don't really feel good about giving people old blood, right? Most of our patients would say, no, please, like you, Sarah, please give me the fresh blood. So now I'll ask you, and Sarah's sitting far away from this as well, if you look at this picture, would you say that older is better or fresher is better? Or it doesn't matter?
I mean, it looks like there's more dots to the right, so older is statistically better, it
Could be.
seems.
Now, I'll just add a little bit. Wherever you can see a confidence limit here, if it overlaps this line, then it means there's actually no difference.
Okay, well then there's probably not much of a difference.
Yeah, but you're right. We have kind of one point that's where clearly older is better, but the rest are pretty much hovering around there's no difference. So I don't know, Sarah, if you would change your answer. You may still say, I don't care, give me fresh. But as somebody in the hospital who's going to actually pull the blood off, at least what you can say now is by looking at a whole bunch of different subgroups, which is really not the focus of this discussion, but just so you know, we're looking at different blood types, we're looking at sicker people versus healthier people. Down here, we're saying, well, gosh, what outcome should we choose? I mean, should we choose death within a day? Should we choose death within 6 months? Should we look at fevers? I mean, what would count? How would we know if older blood was worse, right? There are lots of patient subpopulations. There are lots of different ways that we could count something as having been bad. What this picture is doing is it's saying, you know what, rather than just saying we're going to choose one patient population and one perfect way to measure whether or not older or fresher was better. We're going to look at all the ways. And if all of the ways are telling us the same answer, then we'll feel really good, right? Then our lack of definitional agreement doesn't matter so much because frankly, it doesn't matter which definition you choose. You can use a definition that includes sicker people or healthier people. You can choose immediate death or longer death. We won't choose taste. But that's the important thing, and this is called sensitivity analysis. And what does this boil down to? So if you came in and your chief complaint, rather than I broke my arm or I'm having a heart attack, was, we cannot move as an organization because we can't agree on the definitions, then what we would suggest is that a single version of truth is actually illusory, and we should stop. Because in health and healthcare, you all on the phone will likely know better than me, there is no perfect definition of readmission. There's no perfect definition of a good outcome. There are as many definitions as a good outcome as there are people. There's no such thing as a perfect treatment either. People have different preferences. I don't know that we'll find someone who said, yeah, give me the old blood. But for sure, we have differences with people who want to be screened or not screened for certain diseases based on what they would do with that information. We have differences in whether people would like to pursue aggressive or less aggressive treatments based on their goals and preferences. So we know that we're not going to have perfect definitions in health and healthcare because our members and patients have differences of opinion about what would count as best for them. So instead, what we suggest, rather than pursuing the single version of truth, is to pursue a convergence of evidence and then approach differences with curiosity as an opportunity to understand. So in this case, it was pretty clear cut. It doesn't really matter if you use older or fresher blood. I mean, none of this was like 3-year-old blood. So, people thought it was safe, but they just wanted to check. And there's a specific technique that if you're not an analyst, you can ask your analysts to perhaps test out and embrace, which is called sensitivity analysis. And if you are an analytic professional yourself and you're familiar with it, sensitivity analysis that is, then perhaps your leaders will be more supportive of you getting to use what you've learned in the past. If you're an analytic professional and don't know about sensitivity analysis, then perhaps it's something that you can learn more about and again bring to your organization as a way to bust through that chief complaint of we can't agree on the perfect definition for whatever it is that you're trying to improve. Okay, so we'll go back now, and Sarah, I'm sort of, if someone raises a hand and says, I have a major issue with what you've just said, please do let me know.
We did have Chris did ask, what is the definition of fresh and what is old in this example?
Okay, so that's Chris, that's a wonderful question, and you probably can't see it, but I have actually included the link to the New England Journal of Medicine article at the bottom, and you can read the entire study, which was a pretty cool study, and there have been several others. But if you're in the blood bank world, I'll tell you that I once shared this with a blood bank runner, and they said, well, none of that blood was really that unfresh. It was all pretty good. So I'm not an expert in that area, but take a look at the article and see what you think. And again, the link to it is in the bottom left-hand corner should you download the slides. Anything else that's leaping out of the audience at this point?
Not right now.
Okay. No one's suggesting I get a transfusion of super old blood. Okay. What was number 3 on the list?
Number 3 was the low analytic throughput. And when you kicked that off, we had a question from Chris who had asked, what is low analytic throughut? So maybe you can set the stage before you dive in.
Right. That's one of my favorite examples in the ED where some per diem or daily worker in the ED called a code stroke in the hospital. It just introduced what code stroke meant, and the entire hospital fell upon this person who thought he was just going to send the patient off for an MRI. Okay, so low analytic throughput, what is it? So low analytic throughput you might complain about if you find yourself in a situation where you ask your analytic team for an answer to a question, and they say, thank you very much, we've stuck it in the queue, we'll get back to you somewhere between 6 months and 600 years. That would count as low analytic throughput, which from your perspective is, I needed the answer faster than you're able to provide it to me. So that is when you would complain about low analytic throughput. And I'm glad that this wasn't the number one problem. As an analytic professional, I'll maybe speak for some of us when I say it certainly feels like we can never produce the information fast enough. We wish our throughput could be faster. And so this is a practical example of what we have found can be really helpful in increasing your analytic throughput. And it's going to sound a little weird. So let me start by saying often what we are asked to produce is a predictive model. So remember that Gartner chart said that was like level 3 in your analytic ascendancy, and it's not as valuable as being able to do basic descriptive statistics or reporting. But actually, we have found that if we can really nail those basic descriptive statistics and reporting, and especially if we can visualize information over time, it can accelerate our analytic throughput by a factor of about 10, and especially predictive models. This has a massive impact because what really happens often is that we're asked to do an analysis, and when we go in to do the analysis on a really important problem, it turns out that we're among the first people to really dig into the data. We often don't have the clinical or operational expertise to know what we're looking at, and so we spend the vast majority of our time, and by that I mean like 80 to 90% of a new analytic project is actually spent hunting, gathering, and cleaning data. So how can we accelerate that? Well, one is to be able to start any analytic project with a basic visualization of what are we seeing in the data. And here we would suggest using a statistical process control chart because it does a couple of things for us. First off, we can't build the chart until we've clearly identified a population. So if we're trying to look at hospital discharges, what's going to be our definition of a discharge? And that may seem trivial, but do we want to include someone who only went through observation and wasn't admitted as an inpatient as a discharge? Do we want to include all ages, or do we want to exclude pediatric cases? So these are all reasonable questions that people could ask. And if we've been looking at the data and have a sense of what counts, what's our discharge count by month, then we're in a much better spot to start the analytic process. The other is it helps you identify an outcome. So if the thing that we were trying to improve, since we're talking about hospital discharges, the common ones are trying to improve on length of stay or readmission or mortality or something like that, then it would have also forced us to define that outcome. We would have had to define what counts as a readmission, what counts as a long length of stay, what counts as a mortality. And so we would have already started with those population and outcome definitions, and that can immediately shave off months and months of back and forth, or even having accidentally provided the wrong answer because we thought we knew what people meant by a discharge or a readmission when we really didn't. The other thing that it does is it immediately helps us understand the kind of variability that we're seeing over time. So if you're not familiar with the statistical process control chart, we have sort of a central line here that's telling us we have just below 450 discharges a month. But we do see some volatility. So here we have in January was a low month, and statistically significantly so. We're also seeing as we go over to the right-hand side of this chart that we have a series of recent points where the discharges seem to be quite a bit higher. And now what we have the opportunity to ask is this real, or is this a problem with the data? And if it's a problem with the data, then we need to go back and fix something. If it's real, it may tell us we need to rethink how it is that we're going to do our analysis. Are the discharges in the recent time period really similar to those in the past? How should we think about that as we go forward? So it helps us see things with our clinical, operational, and the other experts that we're working with to really accelerate dramatically, again, tenfold, dramatically increase the analytic process. Since we've already talked about computer-generated forecasts, we can take this one step further and have the computer add a projection. And visually, we can all look at this. And Sarah, you know nothing about this hospital or this case, but what's the computer telling you about the trend going forward? Are we going to forever be increasing our discharge rate? Is it plateauing? What are you seeing?
Looks like it might be leveling out a little bit, but at a higher level than current.
Absolutely. Yes, that's a great interpretation. And Sarah's a brilliant person, but I don't think she would count herself as either a professional forecaster nor a professional statistician.
Definitely not.
And yet, if she was an expert, she may actually be able to give us a lot of advice about how we can present this more effectively, either verbally or visually, because that is her profession and not mine. But but someone can look at this and pretty quickly draw reasonable and consistent conclusions. And if in that room of experts, somebody knew that actually, no, this is the trend, the recent trend is not real and there's a problem with the data, we could fix it. If we agreed that this was the quote unquote new normal, which is what this forecast is suggesting, then we would be able to think about how it is that we want to deal with it. And if someone said, no, actually, I think that this trend is going to continue to increase, we have not yet reached the plateau, then we would think about things differently again. And I'll just say in this particular example, this bump that we're seeing happens to be because a nearby hospital closed. And so the conclusion was that actually we had reached a new normal unless a new hospital opens up. And we need to think about that carefully. We're going to be getting different kinds of patients as a result of that hospital closing than we've gotten in the past, because it was a specific type of a hospital that closed. So
you did have a question from Jordan.
Yes.
Just he wanted a reminder of the type of graph this is that you're looking at here.
Oh, wonderful. So this is called a statistical process control, or SPC chart. And we've augmented it a little bit with some of our AI techniques to not only highlight where we're seeing important differences, or these orange dots indicate possibly important trends, but we've augmented it further by adding a machine learning forecast to the tail of it to help us understand not only where are we and where have we been, but if history is a guide, where might we be going, and do we believe that trajectory? So Sarah, I think I'm noticing that we're at time.
We are
We
1
are
minute
at
out.
time. And so I think I should turn the time over to you, unless people would like to stay later, but at least you should be able to close out and take people to your closing comments, correct?
Yeah, if you can just scroll through quickly to our slide about the Healthcare Analytics Summit.
Yes.
I will go ahead and launch a poll question here. So before we move into the Q&A, or Jason wraps up these last few slides, we have a few giveaways for complimentary Healthcare Analytics Summit registrations. This is an annual event with more than 1,000 provider and payer attendees occurring this year, September 10th to 12th in Salt Lake City, Utah. And it's going to feature brilliant keynote speakers from the healthcare industry and beyond. This is just a glimpse at some of the speakers that we will have this year. So then in this first poll question, if you know that you're able to attend and are interested in being considered for complimentary passes for a team of 3 to attend the Healthcare Analytics Summit, please answer this poll question. We're just going to give you a few moments here. So these are going to be quick, so you're going to have to act fast. All right, we're going to do a 3, 2, 1, closing that poll. And then moving on to our second. I'll go ahead and launch this one. And in this poll, if you know that you're able to attend and are interested in being considered for a complimentary individual pass to attend the Healthcare Analytics Summit, please answer this poll question. So maybe you can't get your whole team, but you're still interested in attending, please let us know here, and we'll be sure that you're considered. Okay, we'll give you just one more second there. And then we're going to go ahead and close that one. And then I have one more poll question, which we'll fly through. Okay. While today's webinar was focused on the use of AI in healthcare, some of you may want to learn more about the work that Health Catalyst is doing in this space, or maybe you'd like to learn more about our other products or professional services. If you are one of these individuals that would like to learn more, please answer this poll question. We'll give you just a moment here to respond. And you've started getting lots of praise in the comments section, Jason. So I think we'll have some good questions lined up for you, but We'll give you all just one more minute here before we turn the time back to Jason. Okay, I'm going to do another quick countdown here. Give you your chance to respond to this poll. We're going to do a 3, 2, 1, and we're closing that poll. Okay, now you're welcome to just navigate back to where you were in the slides, or
What about Ryan?
about Ryan?
Ryan's session?
Oh yeah, I'll still cover that at the end. But
okay.
Yeah, Jason's just mentioning we do have a webinar coming up on August 28th with Ryan Smith from our internal Health Catalyst team. He's a Senior Vice President and Executive Advisor, and he'll be presenting a webinar for us on August 28th again. And we do encourage you to join us for that, but I'll remind you about that again when we get ready to close. But
so how are we doing? Are people still on?
You still have 180 folks on the line.
Okay, so if, maybe I wish we could ask what people like to discuss, or maybe there's some questions that we can take.
Yeah, we can pull those up.
And I'll go back. Whoops, I have to remember to click. And I'll go back to where we were. So any points of clarification or other comments, substantive comments?
So far, just a lot of praise. We've had a few questions. And one person wants to know if you're willing to share your email address. I can send that privately if you want.
Yes, of course. I'm sorry. I thought I'd included that somewhere, but I probably forgot.
Okay. I mean, we have a few questions if you want to get into that. Do you want to do those first, or do you want to keep going through your section?
Okay, so what I should know by now by process of elimination what the last one was.
You still have pilotitis was the next, and then the don't believe results. And someone actually just asked for the definition of pilotitis, so that kind of ties in.
So pilotitis, I have to give credit to when I had the great fortune to work at Kaiser Permanente for this. One of the leaders there used to use it regularly. So pilotitis is where you find yourself in your organization perpetually running pilots. So I've known organizations that have had well over 100 pilots going in a specific area. And what that's telling you is that there's definitely demand for some kind of improvement, or there's some kind of excitement out there. But if you have 100 of these things or more going on at the same time in the same trying to solve the same basic problem, is going to be almost impossible to learn. And what we routinely find is that these pilots can go on for way too long. So you initially thought, oh, we'll run a pilot for a couple months and then we'll get the answer and we'll make a decision. And then you wake up 5 years later and you find that you're still running a pilot with inadequate resources and people are stressed. So pilotitis is having too many pilots going on at the same time, or they're going on for too long. Okay, so then the other thing, and the reason why there's not a link to that is because what we've been discussing this whole time is how it is that you can avoid pilotitis. So if we go back to that books and worms example, where the study was, let's give kids books and it'll help them out. Because we conducted a good study, we were able to, or others were able to determine actually that's not going to help, which allowed them to fairly rapidly draw a helpful conclusion that actually deworming was going to be helpful. Similarly, if we use the techniques that we've talked about already for low analytic throughput, which is the use of things like statistical process control charts, then we can more quickly understand whether or not things are working and we should turn them on or off or support them with more gusto. The data literacy, again, is not running away from statistics and machine learning techniques, but actually embracing them to help us understand whether things are working or in what direction they're going sooner than later. The lack of agreement on definitions, again, can help us with pilotitis, because often what we find is the pilots start because people disagree about the perfect patient or member subpopulation. They disagree about the outcome to measure. They disagree about certain aspects of the processes, and we can use techniques like sensitivity analysis to embrace many different reasonable definitions and then ask and answer the question, what seems to be working? Are we getting a consistent answer? Do we have an opportunity to learn from outliers? So I guess the thing that we haven't talked about yet is not believing the results. And I was surprised a little that this wasn't more common. And before I go to it, any further clarification or questions that we should address before moving on?
I don't think so. Nothing that's tied specifically to any of these topics. We just
Okay.
have some more broad questions that we can get to later.
And how should we know when we should stop?
That depends on your availability personally.
Okay. So I'll cover this last one. And then please, if you have questions or comments, type them in. I'll be happy to respond to them. This is, I hope it feels like your time. Okay, so what happens if people don't believe the results? And the most common thing that we run into in healthcare is often the sort of three-step process for being willing to use data. Step one, when you present someone with a conclusion, is, well, your data are wrong. We talked about that a little bit already, and maybe the data are wrong. But once we get the data correct, the next answer that I'm sure many of us have provided or received is, okay, your data are correct, but my patients are sicker. So I believe the conclusion. If I was that geography 7, I believe that actually, in fact, our performance is not as good as the other geographies, but that's because our patients are sicker. I once had the wonderful response that a readmission rate was higher not because patients were sicker, but because patients were smarter. You might ask yourself, Sarah, any idea why smarter patients might increase their readmission risk?
Maybe they're the WebMDers out there.
Could be.
They think they know what they have, even though, you know, WebMD says everything's cancer, right?
You're
that's my guess.
Spot on. The thinking was, our patients are smarter, therefore they don't follow what we ask them to do, and then they end up getting readmitted. And that's why our readmission rate is too high. So there are all kinds of reasons, but basically what this is getting to, and it's perhaps the most difficult chief complaint to address because it's often not symptomatic, is we find that there is confounding going on. And you may not know what confounding is, so I'll describe it briefly. But in short, it's the maybe my patients are sicker. So what we're really interested in is the relationship between A and B. This could be a treatment, it could be some kind of exposure to a pathogen or something else, but we're interested in this relationship between A and B. And for instance, what hospital are you at and what's your readmission risk? And the problem is that there's some other thing, this thing C, that is influencing both what hospital you're at, or is associated both with the hospital and with the outcome. So in the example we gave of the patients are too smart, we had the smart patients are disproportionately going to one of the hospitals, and those smart patients are not doing what we say, which increases their risk of readmission. So that's the definition of a confounder. And the cool thing is, if we can surface ideas about what might be confounding the relationship, then we can deal with these things either through study design or through analytic techniques. So if we only have retrospective data and we can't change our study going forward, then we can deal with these statistically head on and be able to address these confounders so that we can ask ourselves, you know, is it really the IQ or other measure of smartness of your patients, or is there really an issue here? And we've already seen one of the ways that we can deal with it, which is a sensitivity analysis. But for those of you who read medical journals, then again, we have a relatively small image, but you'll be well familiar with what you almost always see in any medical journal as table 1. In this case, we're again looking at that blood bank example, and here we have our short-term storage and our older blood. We can see we had about just over 2,500 patients in each of the arms, and it's looking directly at, did we have any underlying differences in the population? Was one population older? Was one population more likely to be male? Did they have different primary diagnoses? We might imagine if someone's in there for trauma, their need for blood is going to be perhaps different than if they're in there for a gastrointestinal condition or a kidney condition or something else. So these are all reasonable ways that someone could say, Sarah, you could say, I don't believe you that it's okay for me to get older blood because I'm different. I'm sicker or less sick, younger or older, female versus male, have this problem or that other problem for being in the hospital in the first place. And when we look at this, what we're seeing is that there are no meaningful differences between the population. But I'll ask you, how often in your routine analytics are you on the webinar actually presenting something like a table 1 so that when someone comes back to you and says, I don't believe your answer, that you've thought through what reasonable confounders there might be and actually done the analysis to show whether or not there are differences or not. And if there are differences, how are you dealing with it? And there are techniques that we could cover for how to deal with it. This is an addressable problem where we can apply well-known methods. Moreover, if you have the opportunity, if you're blessed with somebody who will tell you they don't believe your answer, what a wonderful chance to say, well, why? What is it about your patients, your members, your unit, whatever? What is it that you think is different? And if you hadn't thought about it beforehand, go back and add it. And now you've engaged someone, which is what gets us hopefully to that third stage of data and analysis, which is, okay, I believe that the answer is reasonable, and now we're going to do something about it. So again, the idea here, as we go back to each of these chief complaints, is that for each of them, there's something specific that we can do to address the chief complaint. And for some of you, my hope is these are things that you can do or at least ask or make progress on next Tuesday. We don't have to reinvent wheels. We do have ways that we can address these chief complaints. So I will stop there.
All right.
And I'm sorry that I went over. I mistimed how long it would take, but I am happy to address any questions or relay thoughts to the broader audience that you may want to share.
Okay. Yeah, and you had tons of praise coming in, so
Okay.
I wouldn't worry about going too long. But so here's a question from Ed who says, I know single version of the truth is illusory. That said, we have a challenge of standardizing certain key processes in the EHR, which requires a single version of the truth to ensure data integrity. Thoughts?
Gosh, Ed, my initial thought as someone who routinely works with EHR data is I sometimes long for standards, at least in some places. My favorite example is the problem list, where unfortunately the problem list, which is where physicians will often enter what problems a patient or a member has, there isn't really strong guidance about how to use that list. And because people use it in so many different ways, it's very difficult then to aggregate data from a problem list and make heads or tails of it. But I'm guessing that maybe some of the things that you might be referring to are around documentation. And if you could give an example of a regulatory example that has caused a problem for you, I would be grateful.
Okay. Next question comes from Max, who says, change management. What's your recommendation or strategy for incorporating data in change management?
Oh, that's a great question. And Ed, if you type something in, I just wanted to be clear. I was asking if you could clarify so that I could come back with a more informed, hopefully more informed and helpful comment. So please do respond if you're still there and have willingness. Okay, so yeah, data I think can be wonderful for change management for a couple of reasons. One is, in the absence of data, we are we are left with the loudest or strongest voice in a room syndrome, and that is not always the most helpful way. It's usually not the most helpful way for an organization to move forward. So simply being able to bring data to the conversation I have had the great fortune of witnessing both at the bedside as well as in the boardroom how the presentation of data can shift the discussion um, from I guess heated and impassioned debates about largely irrelevant information to refocusing the discussion where it needs to be, which is what's the problem we're trying to solve and how do we think we might solve it. But beyond that, a lot of what we've been talking about here are some of the techniques to facilitate, to leverage data to facilitate change management, and it's using data specifically to engage people. So rather than analysts going off into the basement and coming up with great predictive models or great reports or something like that, showing data to clinical and operational and other leaders in the organization is a great way to engage them in the process. It's also a great way to help set a common level in the organization so that we are making visible what people might otherwise be concluding internally. So if we go back to this data literacy example, without showing these diamonds, people are having to make up in their own minds where it is that different geographies tend to be headed. And even if it turns out that someone with great knowledge of this geography 4 knows that actually, although the trend indicates they're going to improve, this person with extensive knowledge knows that that's not going to happen for a specific reason. They've in fact hit a plateau. They know that resources are being removed or something else. Even if the report is wrong, it's given the opportunity for that person to disagree with it openly, so that the entire organization understands what's going on, or at least can discuss what's going on. And so often what we find in organizations is without being able to make visible what's going on in people's minds, we get 6, 12, 18 months down the road and then uncover why it is that the change we hope to see hadn't happened. Being able to present the information consistently for all to share and consume and give their opinions on can greatly facilitate the change management process. I hope that helps.
Okay, we'll do a few more questions here. This one comes from Dongsel, who asks, in a predictive model, what would you suggest to handle confounders? Do you include them in the model development regardless? And how would you handle effect modifiers?
Okay. So confounding and effect modification are highly related to each other. So there are a couple ways that I would address it. So first off, we don't care about confounders, historical confounders in a prediction problem. So if we go to the example that we were looking at here, why am I not? It's not going forward the way that I'd expected. So let me go back to chief complaint. Okay, don't believe the results. So let's say we had something like IQ really was driving a readmission rate, and we had measured IQ. We do care about IQ as an effect modifier in trying to conclude whether or not either the hospital or the IQ is related to readmission. But for the purposes of trying to understand whether we can predict that a patient is more likely to be readmitted, we actually don't care if there's confounding going on. We can include both the hospital and the IQ of the patient in our predictive model and still get a reasonable prediction about their likelihood of being readmitted. So that's one answer as it relates to prediction. The thing where we want to be really, really careful about is, now let's say this is not IQ anymore and it was some sort of an intervention. Let's say that it was a post-discharge follow-up phone call and we didn't know that it was happening. And so now what we're seeing is our ability to predict readmission is declining over time, and it's declining because we're doing a good job of post-discharge follow-up phone calls. Where will that matter? That will matter because before we conclude that our predictive model is bad, we need to be able to account for how it is that the interventions may be tweaking, maybe quote unquote messing up our predictive model. So I hope that has helped somewhat. It depends on what the nature of the confounder is and how it relates to the thing you're trying to predict and the problem you're trying to solve.
Okay, I think we'll do these last two questions.
Okay, did Ed get back to us with an example? Okay.
Oh, just now. He said, this is behavioral health and challenge of getting buy-in to adhere to standardized process for establishing episode of care so we can accurately track length of stay and by extension evaluate treatment outcome from admission to follow-up. Some of it is lack of data literacy of the managers and other is lack of buy-in.
Okay. So that, gosh, Ed, when we stick the email address up there, maybe we can have more of a discussion. First off, thanks for focusing on mental health and wellness. And that is a particularly challenging area as it relates to standard documentation. But what I would read from your comment, and Sarah, please tell me if you think I'm missing something, it feels there as though one of two things is going on. Either we don't have an accepted standard and the documentation is all over the map, which makes it difficult to conclude anything, or the regulations are requiring us to document things that don't matter and therefore or are not measuring things the way that we want to, and therefore don't have the time or energy to measure the things that we should. The second point, do you think I got it right?
I do.
Sarah? Okay. So that second point is actually really common in health and healthcare, where the burden of documentation, the requirements from regulations, it's not that the regulation itself is obviously the worst way to measure something. It's that there's so many of them and so many rules about how you all have to document that you don't have the energy to document the thing that we know matters. And an example there that I've seen, not in mental health and wellness, is in surgery, where we have to spend so much time capturing risk factors and documenting things like surgical site infections, that we don't have the time and energy left to be able to capture how's the patient actually doing. If they got their hip replaced, are they actually able to walk better 3, 6, 12 months later? Because we're spending all of our time on risk adjustment factors for surgical site infection per maybe not regulations, but voluntary reporting that our organization would like to participate in. So Ed, happy to follow up further. Mental health and wellness is a personal passion, and anything that I could do to help, I would leap at. So thank you.
Okay, I think we'll just do one more. This question's from Vinod, who asks, how do you deal with latency in obtaining different types of data, like claims data, clinical data? Any tips there?
Yeah, you know what? That is a wonderful question. I will quickly go back to our SPC chart here, which is analytic throughput. And I can tell you that the very next SPC chart underneath this one was the readmission rate. And what we saw is that routinely, this last data point was always very low, precisely for the reason that was just mentioned, because there was a latency. Why did that happen? Well, because we know when the patient's discharged, but for a readmission, we have to give them at least 30 days to be readmitted, and then at least another couple weeks for the claim to come in. So what I would suggest is that we, again, use these visualizations and charts to help us understand the nature of the latency, and then we can ask ourselves, is there anything we can do to reduce latency? And in the case of readmission, the answer may be no. We have to give someone a chance to get readmitted. But in other cases, there may be ways to reduce the data latency. And then we can, like a claims lag, and we can ask ourselves if we're willing to take the steps to do so. Thanks, that's a great question.
All right, on that note, I think we're gonna wrap things up. Thank you, Jason, for the extra 25 bonus minutes there of Q&A time. So we do want to thank Jason for joining us today, and for all of you for staying on the line here an extra 25 minutes past. Please do us a favor and complete the short survey as you exit the presentation. Your answers will help us to deliver more valuable content in the future. As a reminder, by midday tomorrow, you will receive an email with links to an on-demand recording, the presentation slides, and a transcription. We'd also like to invite you to join us for our next webinar, Platforms and Partnerships, the Building Blocks for Digital Innovation, which will be held on Wednesday, August 28th. This presentation will feature Health Catalyst's Senior Vice President and Executive Advisor, Ryan Smith, who will explore why our industry is struggling to provide the tools and self-service experiences that patients and consumers have come to expect in every other aspect of their lives. On behalf of Jason and all of us here at Health Catalyst, thank you for joining us today. This webinar is now concluded.